request the quiz team to please take over and set the stage for the 4 teams.
For the last 2 days, actually, we have been hearing to all our seniors, colleagues, their experiences. But what ultimately happens is when we see a patient, we are confronted with questions, yes or no type questions, or sometimes what should be done next. So that is what we are going to do now. The most interesting part of any conference for all the postgraduates is something like papers and quiz. So we'll try to make it as funny or as interesting as possible. Because of shortage of time, we are trying to be little faster. So postgraduates, please cooperate with us, and all of those who have given their names for the quiz, I request them to come forward. These are the names: Raja, Sai Aishwarya, Suryavanshi, Ajasri, Rohit Sharma, Srija, Sahiti, Nainasri, Bhavna, Prashant Kumar, Charan, Rishabh, Muhammad Faisal, Ishani and Padmalata. All of you are here. Please come. All of you make teams of 4 each. 4 each. So may I have the first 4? Come. Who are the 4? Make it fast. Swarna madam is my professor and she will be very strict if I don't finish. I am afraid, at least. Please come first. Yeah. So another 4. Okay, you are 4. You are 4. Another team of 4 members. Another 4. You have your 4. Your 3. So just pick up one friend. That's all. No, this is also there. Come. So we have all the teams. You are 4. Another person. Call out your 4 are there? Okay, yeah. So next, take your sheet. We have another 4 numbers actually. We have total 16 people. So any other PGs joining us?
Hello.
Wild entry is also acceptable. Another 4. Okay, take the slip. So any others? Or otherwise you just make 3 and make a, they have come. Okay. So another. So, who got the nephrotic syndrome in your slip? So you sit in the first. You are team A. Who got the AKI? AKI. Yeah, you sat in the right position. The next one. CKD. CKD is a 3rd. C. CKD, please go to team C. Transplant. Team 4. No problem. Write your name. Okay? 4 of you. Then we'll just. Yeah, all of you settle. So you are only 2 people. They are 4. So you need another 2 people. Any other 2 PGs? Or yeah, one from. Then we can make it 3. 3. Oh. Say one, come and help me. Who wants to come and help me? I'll give you another prize. Come. Who wants to help me? Yeah. Come Rohit. Really, I'll remember your name and I'll really help you. Come. Thank you. So one of you join here. 3. It's a team of 3 now. Oh, you came here. You don't want to help me. Oh, come. You are our team now.
So one from team B and C shift to this side.
We'll make it 3, madam. 3. One of you come here.
One from team C shift to team D.
No, ma'am. Already there are 3. So
okay.
one have to come out then. No. Because
One of you-
come out. Come and help us. Hey, don't worry, you will have your prizes. Okay? Come. Thank you so much. So this is team A, this is team B, and this is team C and team D. And I am Dr. Sivaparathi. I am a consultant nephrologist at Amara Hospital. And Dr. Vani madam is hosting the quiz along with me. She is from Karnool Kidney Center. So now the theme is really based on nutrition and metabolism. Depending upon the clinical situations, usually every quiz will have a rapid fire round at the end. But this time we thought we will have a clinical case scenarios and a bunch of questions following the clinical case scenarios. So we will start with the first round, and these are some of the rules. But one hashtag is whatever the quiz master says, that is correct, just to avoid the controversies at the end. So we'll go with the round one. Dr. Vani madam. So wish you all good luck. Okay.
So we'll move on to the first round. It's a rapid fire round. We'll be given clinical scenarios and 10 questions, and these are like yes or no or true or false questions. Okay. If you give right answer, you will get 2 marks for each question. So coming to round one, nephrotic syndrome. It is for team A. A case of 8-year-old child with nephrotic syndrome with weight of 20 kg, urine proteinuria of 10 gram per day, anemic with HB of 6.5, with SBP of 100/60, and complaining of giddiness on standing with pedal edema, blood urea of 30, creatinine of 0.5. So anemia and nephrotic syndrome with normal renal function can be treated by erythropoietin. True or false? So answer is wrong. Daily production of albumin from liver. Otherwise pass. Protein loss in urine can be replaced by increasing protein intake. True or false? False. That's wrong answer. Lipoprotein lipase activity in nephrotic syndrome flare increased or decreased? Wrong. The minerals lost in nephrotic child needs to be replaced all except magnesium, copper, zinc, iron. Huh? The underfill hypothesis of edema formation in nephrotic syndrome starts with hypoalbuminemia or sodium retention. Which is correct? Correct. Does AC inhibitors or ARB will reduce dyslipidemia? Yes or no? Correct. Can we use diuretics for this patient to treat edema? No, she is having orthostatic hypotension contest. Her protein requirement is 20 gram per day or 10 gram per day or 30 gram per day. Which is correct? Correct. In nephrotic syndrome, hypoalbuminemia is due to renal loss of protein, increased fractional catabolism of albumin, or both. Correct. So total. Okay. The second case is AKI. It is for group B. A case of urosepsis presented with elevated creatinine of 1.5 times baseline. Stage 2 AKI initially, later progressed to anuria and creatinine of 4, bilirubin of 2, AKI and MODS, and developed hypotension. This is the scenario. And which is the best fluid of choice for this patient? Inodrops, normal saline, DNS, balanced salt solution.
Normal saline.
Wrong. The amount of calorie required is 30 kilocalorie per kg or 40 kilocalorie per kg. How to decide which is the test and which is the test that guides to you for the further therapy?
We'll go with 30 kilocalories per kg.
Answer is right, but what is the test that guides whether it is hypercatabolic or normocatabolic to decide?
Pass.
So this is the indirect calorimetry. It gives us resting energy expenditure. Due to paucity of time, I am not giving. Okay. So how much percentage of total energy expenditure is to be administered in early days of AKI? 100%, 75%, 50%, or 25%?
We'll go with 50%. C.
So it's a 75%. So So this is the figure from clinical medicine. Due to gluconeogenesis in early part of AKI, we should not treat completely. SGA involves all of the following except dietary intake, GI symptoms, weight change, serum sodium.
Serum sodium.
Correct. Patient on medication nutrition, which is true, on medical nutrition therapy, which is true. High percentage of energy from lipid than carbohydrate, or high percentage of energy from carbohydrate or lipid than lipid.
High percentage energy from lipid than carbohydrate.
Correct. Patient developed quadriparesis and CRRT therapy. What may be the common cause?
Electrolyte abnormality like hypokalemia.
Correct. Initiation on TPN, total parental nutrition during CRRT therapy. The most complication with TPN, the most common complication.
Hypophosphatemia.
Hyperglycemia is the first initial manifestation. No. The percentage of body weight used for protein requirement calculation. So the present body weight is used for protein requirement calculation. Is it true or false?
As in the actual body weight which is given here.
So is it true or false?
False.
Correct. Do you advise glutamine amino acid infusion therapy for this patient as per guidelines?
No.
Correct. So questions to see stage 3. A 50-year-old male with diabetes since 10 years, creatinine of 2.3, stage 3 CKD with proteinuria of 4.5, and DAPA and ARB started and with edema, his potassium is 5.3. The protein intake you advise for the patient per day as per Kedoki. 0.4, 0.6, 0.8, 1.
0.6 grams.
Wrong. Wanted to add finerenone to the prescription. All the following can be advised except to stop fruits and vegetables, advise leaching, correct hypoglycemia, correct metabolic acidosis.
Correct hyperglycemia.
Huh?
C.
Wrong. To stop fruits and vegetables. We should not stop them. Serum creatinine is increased and progress to stage 4 CKD. Want to cut down the potassium further and want to shift to millet diet. Which millet diet is you advise? Pearl millet, sajjalu, finger millet, ragulu, foxtail millet, koralu, and barnyard millet, udalu.
Pass.
That is barnyard millet. Developed bone pains and evaluation. What is the diagnosis?
This is a high turnover bone disease.
High turnover, that is a brown tumor.
Brown tumor.
Okay. What diet advice do you want to give except for this condition? Phosphate binders, plant-based protein food, avoid animal protein, take yellow yolk of the egg.
4.
Correct. Yellow yolk contains high phosphorus. So developed edema, which is the best test to identify malnutrition versus protein energy wasting in the presence of edema. SGA, DEXA, BIA or MRI?
C.
Wrong. DEXA is correct. His ABG suggestive of metabolic acidosis. What are the measures to be taken to combat acidosis except add exogenous alkali, shift to vegan diet, vegetarian diet, protein restriction, vitamin D fortification?
C.
Wrong. D. Indications for oral supplementation in CKD patient. Weight loss of 5% over 1 month in acute illness over CKD. Weight loss of 7.5% over 1 month in CKD. Eating less than 75% of usual meal for at least 1 month for coexisting chronic illness. All of the above. All are appetite stimulants except megestrol, melatonin, cyproheptadine, thyroxine.
Melatonin.
Wrong. Thyroxine. Over 2 years, serum creatinine progressed and MHD initiated, but due to protein energy wasting, he needs IDPN, intradialytic parenteral nutrition. All are true about IDPN except 30% of nutrients are lost in dialysis, gut nutrient access advantage is lost, can be given only 3 days a week, first option for protein energy wasting. All except
D.
D, correct. So moving to group D, a 17-year-old female CKD on MHD with weight of 30 kg And her ideal body weight is 45 through divine formula, and hypertensive on 4 drugs, underwent transplantation with grandmother as the donor, with induction with ATG 2 mg per kg on triple immunosuppression, was on TAC of 2 mg twice a day to maintain TAC level of 8 nanogram per ml, and develop NODAT. To calculate MIS score for her, she needs which of the following except albumin, pre-albumin, TIBC, BMI?
BMI.
Wrong, pre-albumin. To improve her pre-transplant weight, she has been advised following food items, among them which is rich source of protein and fiber: egg, telagapindi, defatted sesame, lean meat, fish, which is rich source of protein and fiber. B. Correct. Following are products of whole grains except oatmeal, millet porridge, whole wheat pasta, almond flour.
Whole wheat pasta.
No, almond flour, except immediate post-transplantation, the protein requirement for the patient is 0.4 mg, 0.6, 1 or 1.4.
0.6.
No, immediate post-transplant, her requirement will be high, 1.4. Her calorie need immediate post-transplant is 1200 or 1800 per day, which is correct. Continuation of previous question. Huh? Wrong. What is the risk factor for NODAT? Female sex, age 17 years, grandmother as the donor, hypomagnesemia. Risk factor for NODAT. Yeah, correct. So, was advised DASH diet by the physician. It includes all the following except avocado, banana, coconut oil, black beans. No, coconut oil, saturated fats are there. She developed hypophosphatemia during 2nd month of post-KT. What are the causes except hyperparathyroidism, high FGF23, tacrolimus, ATG? Hypophosphatemia, post-renal transplant.
ATG?
Correct. As part of whole food approach to improve her gut microbiome, the physician advised her all except sesame laddu, fermented foods like idli, dosa, appam, yogurt, meat.
Meat.
Correct. Developed diarrhea and stool microscopy suggestive of amoebiasis. All are true except foodborne disease. Food safety precaution needs to be reinforced. Treated by metronidazole. It is a common zoonotic disease.
Common zoonotic disease.
Correct. At the end of first round, the marks are Team A 8 marks, Team B 10 marks, Team C 3 marks, and Team D 12 marks.
Please clap for them. Actually, it was a rush of questions, but we all made it so that in the OPD patients will just bombard you like that. Okay? Now we will move to the second round. I have an audience question. You want to participate? You just raise your hand and tell the answer. So a patient of CKD stage 3, GFR 31, and albumin excretion is 850 milligrams of creatinine. He was started on fenrinone. So he asked my number, I gave him, madam, if I have any doubt, I will call you, as it is for all of us. So he went to a restaurant. I told him low potassium diet, so he calls me back. Madam, I have avocado, hazelnut, yogurt, sweet potato. Which one should I take? Who wants to answer? I'll come down. Anyone wants to try? Okay, I have a... Madam, just... You tell one because madam said yogurt, but that's not correct. Anyone wants to try? Okay, sir wants to try.
Hazelnut coffee. Among the nuts, if I'm not wrong, cashew nut is also having low potassium.
Yeah, that's a right answer because usually we have multiple options on the cafeteria, cafe latte, cappuccino, hazelnut and all. When we advise low potassium diets, it's very difficult for us to remember all this, but we have to remember. So that's the point that, and thank you, Sashi sir. So that is the audience question. Sir, you will have a prize, but that is later. Yes, no, madam. Actually, it is high. We have the next slide. We have checked the values and because it is artificial yogurt, is in the hotel. You said it is a homemade yogurt. So we'll go to the second round for time. So second round, it is a fun with fusion. Till now you are all alert. Now you don't be alert at all. Just think out of the box and answer. First question. This is to team A. Okay, if you know the answer, you tell. If you don't know the answer, you just, we will give time for 1 minute and we'll pass it to the next one. Question, madam. So you saw the picture? All of you saw the picture? Next. Okay, 30 seconds. What is the clinical condition depicted and what dietary intervention would help in this patient? Your time starts now.
It is rugged jersey spine, madam.
Okay, what is the dietary intervention?
High calcium and low phosphorus diet.
Yeah, okay. So they get the full marks, 10 marks. Usually, potassium, phosphorus restriction will not help you once the rugged jersey spine happens, but I just made it for them. So that's a rugged jersey spine. They get 10 marks, but it is to team B. Second question. The answer we have, yeah. Hey, ma'am. Ma'am, you. Madam, go back. You have seen? Okay, you didn't see, okay. I did, audience, please don't help them. So what is the condition depicted here? You are in the clinic.
Basically, that is a wave, that is a sine wave pattern. And more coconut has more potassium. So I think the overall connect is hyperkalemia here.
That's good. I hope you didn't see the slides.
That wave actually is that wave
They
have been
have
translated into a painting also. So I know that from that.
Okay. So should I give the marks? I will give them. Because they, okay. So they get 10 marks for it. Madam, be careful. Next slide. Okay. So it is to team C. What is the clinical assessment depicted here? You just tell one line about it. Your time is already on.
Skin fold thickness is depicted.
Very good. So, what are you doing there? What is it actually? What is it? Because when I worked in swims, I worked with Sivakumar sir. He asked me to buy it and show to him. And he showed me how to use it.
We'll
Your
check for
time.
the triceps. It's basically the nutritional status of a patient.
Okay. It is Vernier's calipers actually. We use it in the...
Hypertension. Yes, ma'am.
Is it, okay.
Yeah.
So, we use it in SGA for muscle. They get half marks for it. They just get 5. So, next question, madam. Slowly. Okay. Next slide. Okay. So, can you comment on any nutraceutical? I said it's all for fun. Sir, it's for them. They will not. Please. Time. So you just have 10 seconds. Try to connect. No. Time up. Audience.
No. Pass to B. Sivaparathi B. This is
No.
A.
We will finish it off here because we have less time. So because shouting, it's omega 3. Omega 3 fatty acids. It's there in fish. I said it is for fun, right? So that is the end of round 2. Yes. So at the end of round 2, team A gets 10 marks. Team B gets 10 marks. Team C gets 5 marks. Team D, I'm so sorry. But we will go to the third round. It will be also a fast one.
Audience question.
And we have an audience question again.
Sorry.
Okay. Which of the... I think this... No, another round is there. Third round is the last. So which of the following statements about PRAL is false? So PRAL calculates the net acid-base contribution to the body based on dietary intake of protein, phosphorus, potassium, magnesium and calcium. It is expressed in milliclans per 100 grams. PRAL of fish is higher than chicken and PRAL of rice is more than bread. Which is false? Anybody wants to answer?
PRL of fish is higher than chicken. See?
PRL of rice is more than the bread.
Yes, sir. Thank you, sir. So, sir, I'll see your name. Ashmin Dhabi sir said it right answer, because most of the CKD patients, I tell them you have to start dieting. They say like, okay, I will stop rice, because the physician will tell them you are diabetic. But rice is really good for CKD patients if they are not really hyperglycemic, because it is low in potassium and it is also less renal acid load compared to the oats and bread and all. Next slide. Okay, this is the just for you. Okay, now we'll go to the third round. This is the last round. So this is little bit like case scenarios. So these are our IP rounds. So one of your CKD stage 2 patient is admitted in the ward for headache evaluation after a history of exercise. So all of the following is true for nutritional supplementation in exercise. This is for team A. Water is sufficient for less than 1 hour. If it is more than 2 hours, use electrolyte drinks. And the carbohydrate concentration should be 3 to 5%. And caffeine offers hyperhydration but may cause GI side effects. All are true except. It is an except one. Okay. Your time started already. All are true except. "19 seconds, 18 seconds. True except.
Option A, madam.
So you feel it, if it is less than 1 hour, water is not sufficient, right? But it is a wrong answer. Okay, I'll tell the answer. We are not passing because there is a short of time, madam. So the last option is wrong. Usually caffeine causes dehydration. We feel like if we take coffee, it will be good in the exercise also. A lot of people take cold coffees and all. It's not good. It causes dehydration. It doesn't cause hyperhydration. Go to the next question. Okay. So this is for team B. 38-year-old male ultra-marathon runner. He presents to clinic for routine evaluation 2 days after completing a 56 kilometers race. He reports fatigue but no overt symptoms. Vitals are normal. Urine analysis shows mild RBCs. So creatinine is 2. Output is good. Creatine kinase elevated. LDH elevated. CRP elevated. Uric acid is normal. Next slide. Next slide. So, which of the following is the most likely explanation for the lab findings? A, it is ATN due to myoglobin nephropathy. B is prerenal due to volume depletion. And C is increased creatine production from skeletal muscle breakdown. And D is CKD from long-term endurance exercise. This is to team B. Your time starts now. Because this is hot summer, I thought I'll keep some questions on this.
So we'll go with the answer as A, ATN secondary to myoglobin induced nephropathy, because this is a case of rhabdomyolysis and myoglobin can directly cause tubular toxicity in cases of rhabdomyolysis.
Okay,
So I'll
that's
go with
your answer. You want to fix with A? It is a wrong answer. What you have to understand is patient is completely asymptomatic. You have to read the question. It is because of increased creatinine production, and in that situations where you are going to use cystatin C. Okay, this is a question based on metabolism. Now it is to team C. A 52-year-old female, urosepsis, septic shock, dual inotrope support, maximum doses AKI with metabolic acidosis, oliguria, hypotension. She was started on CRRT, NIV support for 36 hours. CRRT was there for 1.5 days. She was fine, everything weaned off, urine output improved and it was stopped. But still we are not able to bring the patient out of NIV support. So what could be which of the following interventions you advise your nurse to add? So this is to team C and your time starts now. Audience, please help me. Don't shout the answers. Yogurt, egg whites, date syrup and smashed banana.
D.
Tell me the answer.
Smashed banana.
It is a wrong answer. Okay. I will tell the answer. It is egg whites. What could be the clinical condition? Madam just told you, no? Long-term CRRT patient difficult to wean off from ventilator. Most common cause is hypophosphatemia. Okay, especially in CRRT patient, more than 24 to 48 hours. So egg whites are rich in phosphorus. Okay. Next question. Yes, ma'am.
Yolk is the one with phosphorus.
With the protein, madam.
White is with protein.
It is egg, madam. Sorry for that. Okay. Next slide. Okay. Protein and phosphorus is my. Okay. So this is the last question to team D. 23-year-old previously healthy man is brought to ED after collapsing after a high intensity outdoor activity. So he is continuously doing it for 45 minutes. He is confused, disoriented, agitated. Vital signs are temperature is 40.5, heart rate is 122, and pressures are 98/60 with respiratory rate is high and 97% room air. So he has a physical examination of flushed hot skin but no evidence of sweating. He is unable to follow the commands but withdraws from pain. The initial lab shows the following. Next slide. Slowly, madam. So creatinine is 2.1 and sodium is 137. CK is more, 9500, and specific gravity is also high. Dark yellow urine. Next slide. So what is the most appropriate next step in the management? Administer dextrose or external cooling, administer dantrolene to reverse the muscle breakdown, and initiate hemodiafiltration for clearance of myoglobin. Your time starts now. Take time and answer. Until you have time, think and answer. Don't rush.
Begin external cooling with ice packs.
Yeah, that's the right answer and they get the marks for it. These two questions I put because we are all going to see these patients in the next 1 to 2 months. At least in Tirupati, the temperatures are 42 degrees. So we have to have a good knowledge of on all these things at present. Next. Audience question? Yeah. So the following diagram explains about. Just see the diagram for a few seconds. I'll give the options for you. Sir, I'll give the options, sir, please. Next slide, madam. It explains which mechanisms. Cisplatin-induced nephrotoxicity, wasting and malnutrition in HD patients, metabolic reprogramming and conversion from AKI to CKD, and lactic acidosis during citrate-based CRRT. Because I put some questions on metabolism, because it is both nutrition and metabolism. Sir, one raise hand, I'll come. Okay, so I have another friend. Madam, you want to tell? Okay. No, madam. You want to tell?
Madam,
Okay.
Manisha.
So he also wants to tell lactic acidosis. Somebody wants to try?
C.
Oh, thank you. That's the right answer. Because I put this slide because a lot of research is going, understanding the metabolism of obesity, CKD. This is called as Warburg effect, which was initially seen in cancer cells. Even in the presence of oxygen, the cells prefer to go for the anaerobic glycolysis, which is very rapid, but it is not energy efficient. That's why it leads to renal fibrosis. And all of us, at least the budding, do some research on that so that we'll have a prevention for CKD, and that's it. We will end the quiz with this, madam, and we will have the scores, final scores.
At the end of the quiz, the team A carries 18 marks, team B 20 marks, team C 8 marks, team D 22 marks. The winner of the quiz is team D.
Oh, team D gets the
22 marks.
Yeah, congratulations, team D. So,
And the second is team B.
Team B gets the second.
And the third is team A.
Okay, ma'am. But all of them are winners because they rushed through your questions. It's
Yeah,
very
yeah.
difficult. Even I could not follow ma'am's questions, but you're really great. Coming forward, a great round for these two people also. They helped me. They wanted to participate, but they helped me. Thank you. Thank you so much. So we'll close.